Moving on to the second section of our lecture, which constitutes of diabetes insipidus. Now, diabetes insipidus is a syndrome that is caused by the deficient production of AVP, and it results in the imbalance of body fluids. It is characterized by large volumes of dilute urine and increased thirst. Let's discuss this topic, this section in detail. In this section, we are going to talk about the etiology of diabetes insipidus, what is the pathophysiology behind this syndrome, and what are the differential diagnosis and treatment. Diabetes insipidus is a syndrome that is characterized by production of abnormally large volume of dilute urine, as I've already told you that, and along with that, there is increased thirst. It is due to the decrease in the production or action of AVP, around 75% or more. The 24-hour urine volume, it increases to 50 ml per kg, whereas the osmolarity decreases to less than 300 milliosmoles per liter, and the specific gravity is less than 1.010. There are certain signs and symptoms of diabetes insipidus. These include enuresis. Enuresis is basically the ability, or the patient has to wake up at night to go to washroom. There will be increased urinary frequency or polyuria, nocturia, or nocturia is the increased frequency of urination at night, and there will be sometimes bedwetting as well. There will be fatigue or somnolence, and as I have told you that it is also associated with increased thirst. If we talk about the etiology, there is insufficient AVP production by the hypothalamus, or there is impaired AVP action on the kidney. It's normal, circulating levels in the blood are normal, but the action of AVP is not is impaired on the kidney. The etiology, it can be primary deficiency of AVP, or the deficiency can be secondary. Primary deficiency is always related to the action, and the secondary deficiency is mainly somewhere in the hypothalamus. The primary deficiency results from agenesis or irreversible destruction of the neurohypophysis or the posterior lobe of pituitary gland. If we divide the etiology, there are mainly 4 types of diabetes insipidus. That is pituitary diabetes insipidus. It has certain acquired causes, and there are congenital and genetic causes. The acquired causes include head trauma, any road traffic accident, or any surgery, certain neoplasms like pituitary tumors or craniopharyngiomas. Then there are granulomas, certain infections like tuberculous meningitis and certain other infections, inflammation, certain chemical toxins, vascular diseases like Sheehan's syndrome, and in around half of the patients, or 1/4 of the cases, the pituitary diabetes insipidus is idiopathic. There are certain congenital malformations that can also cause pituitary diabetes insipidus, and it also has some genetic causes, which we will discuss in the subsequent slides. Then there is another variant of diabetes insipidus, that is gestational diabetes insipidus. As the name indicates, it is related to pregnancy. It occurs during the 2nd and 3rd trimester. Then we have another variant of diabetes insipidus, that is the nephrogenic diabetes insipidus. It can be acquired either due to drugs, metabolic, it can be due to any obstruction, it can be vascular due to certain granulomas, neoplasms, and because of certain infiltrating conditions. and it can also be idiopathic. Nephrogenic diabetes insipidus also has certain genetic causes. The last variant is primary polydipsia. Primary polydipsia is usually acquired, and it can either be psychogenic, dipsogenic, or iatrogenic. Pituitary diabetes insipidus that that is caused by surgery. It usually appears within 24 hours. It transitions to a 2 to 3 week period of inappropriate antidiuresis, but then it comes back to its normal levels, and DI may or may not recur permanently. Now, we will talk about the genetic forms of pituitary diabetes insipidus. There are 5 types of pituitary diabetes genetic forms of pituitary diabetes insipidus. Out of these 5, the most common type is the autosomal dominant mode of inheritance. It is caused by diverse mutations involving the coding region of one allele of the AVP neurophysin gene, the AVP NP2 gene. What happens is whenever there are these mutations occur, they alter the one or more amino acids which are critical for correct processing or folding of the prohormone. Now, when there will be incorrect processing or folding of the prohormone, it will interfere with the trafficking through endoplasmic reticulum. That misfolded mutant precursor, it will start accumulating. And when it will start accumulating, it will interfere with the production of AVP by the normal allele. So it will not let the normal production AVP to be produced by the normal alleles. When the misfolded mutant precursor will accumulate, it will destroy the magnocellular neurons in which it is produced, and the AVP production will be completely shut down. This was the autosomal dominant form we discussed. Now we will see the autosomal recessive forms. These forms are usually rare, and there are 4 types. The type A, it has an inactivating mutation in the AVP neurophysin gene. Type B has a deletion. Now this is important. Type A has the mutation is always in the AVP neurophysin gene, but type A has an inactivating mutation, whereas type B has a large deletion of AVP gene and the regulatory sequences which are present in the intergenic region. Type C, mutations of the 4P WFS1 gene. Now, what is the WFS1 gene? The WFS1 gene is responsible for Wolfram's syndrome, that is characterized by diabetes insipidus, diabetes mellitus, optic atrophy, and neural deafness. There is another X-linked recessive form that is linked to a region on XQ28 chromosome. Now, moving on to the gestational diabetes insipidus, it occurs in the 2nd and 3rd trimester of pregnancy. What is the reason behind gestational diabetes insipidus? There is increased metabolism by an N-terminal aminopeptidase which is being produced by placenta. And this N-terminal aminopeptidase will not allow AVP to stay in the body for a longer time. The signs and symptoms manifest during pregnancy, but it remits after several weeks of delivery. Now this was the primary deficiencies. There are certain secondary deficiencies of AVP secretion, which mainly result from inhibition by excessive intake of fluids. It is referred to as primary polydipsia, and it is further subdivided into 3 subcategories. Number 1 is the dipsogenic diabetes insipidus. The other one is the psychogenic diabetes insipidus, and the third is the iatrogenic diabetes insipidus. If we talk about dipsogenic diabetes insipidus, there is inappropriate thirst that is caused by a reduction in set of osmoregulatory mechanism. Now, the issue that is lying behind the dipsogenic diabetes insipidus is that the osmoregulatory mechanism is impaired in this condition, which results in inappropriate thirst. It occurs in association with multifocal diseases of the brain. Now, the osmoregulatory mechanism is defected because of certain diseases, and these diseases include neurosarcoid, tuberculous meningitis. It can be due to multiple sclerosis, or it can be idiopathic. Now, if we see the psychogenic polydipsia, it is not associated with thirst. It is a feature of psychosis, as the name indicates. The person is either he or she, they might have psychosis, or they have obsessive compulsive disorder, and they keep drinking water. Iatrogenic polydipsia, it results from recommendations to increase the fluid intake, or the presumed health benefits of increased fluid intake lead to iatrogenic polydipsia. Moving on to the nephrogenic diabetes insipidus. If we talk about the etiology of nephrogenic diabetes insipidus, it is caused by AVP resistance in the kidney, the primary deficiency of AVP action. It can be genetic, it can be acquired, and it can be due to certain congenital malformations. The genetic causes are semi-recessive X-linked form is the most common among nephrogenic diabetes insipidus. It is severe in boys and mild in girls. The mutations occur in the coding region of V2 receptor gene. It impairs trafficking or ligand binding of the mutant receptor as compared to the autosomal dominant type of the pituitary diabetes insipidus, in which there is the mutant allele was affecting the trafficking through the endoplasmic reticulum. Here it is also affecting trafficking along with ligand binding of the mutant receptor. There are certain other genetic forms that include autosomal recessive or the dominant forms. They are caused by AQP2 gene mutations, aquaporin 2 gene mutations. They result in complete or partial defects in trafficking. The function of water channels that mediates antidiuresis in distal and collecting tubules of the kidney is affected in these autosomal recessive or dominant forms. If we talk about the secondary deficiency of nephrogenic diabetes insipidus, it results from polyuria that is caused by washout of a medullary concentration gradient. What happens is there will be suppression of the aquaporin function. It usually resolves 24 to 48 hours after the polyuria is corrected. What are the causes that lie behind the secondary deficiency? It can be due to chronic pyelonephritis. It can be due to hypokalemia, hypercalcemia, sickle cell disease, and protein deprivation. All these causes, they can cause the washout of medullary concentration gradient, and they can lead to the nephrogenic diabetes insipidus. Now, if we talk about the pathophysiology, in pituitary gestational or nephrogenic diabetes insipidus, the polyuria results in a small decrease in body water, around 1 to 2%, which is not very significant. But there will be commensurate increase in plasma osmolarity and sodium. What happens when there is commensurate increase in plasma osmolarity and sodium? It will stimulate thirst and a compensatory increase in water intake. Now, hyponatremia and other overt physical or lab signs of dehydration will not develop unless this thirst mechanism is also impaired along with uh, polyuria. So, unless patient also has a defect in thirst or fails to increase the fluid intake, there will be no hypernatremia and there will be no overt physical or lab signs of dehydration because the patient is drinking normally. In pituitary and nephrogenic DI, the severe defect it cannot be overcome by by an intense stimulus. Incomplete or partial defect, however, it can be changed or it can be overcome by a modest stimulus, such as a few hours of fluid deprivation, or smoking, or vasovagal reaction. All these stimuli, in case of an incomplete or partial defect, they increase the urine osmolarity as high as 800 milliosmoles per liter. Now, what happens in primary polydipsia? The pathogenesis of polydipsia and polyuria. It is a reverse of pituitary, nephrogenic, and gestational diabetes insipidus. The primary polydipsia, it is there is an abnormality in cognition or thirst that causes excessive intake of fluids. Due to the excessive intake of fluids, there will be increase in body water that reduces the plasma osmolarity or sodium, and there will be decrease in the AVP secretion. That reduces the plasma osmolarity and sodium, which results in AVP secretion in case of primary polydipsia. And when there is AVP secretion, there will be resultant urinary concentration. Now, the dilution of urine results in a compensatory increase in urinary free water excretion, which offsets the increase in intake, and it stabilizes the plasma osmolarity sodium at a level only 1 to 2% below basal. So the body is trying to compensate all the effects. Hyponatremia or clinically appreciable overhydration is uncommon in this scenario as well. Unless the polydipsia is very severe or the compensatory water diuresis, if it is impaired by a drug or disease, then it will lead to hyponatremia and clinically appreciable overhydration or the signs and symptoms of overhydration. Unless it is not severe, the polydipsia is not severe, it is not going to produce hyponatremia or any signs and symptoms of overhydration. It will stimulate or mimic antidiuretic of the endogenous AVP. Due to that antidiuretic effect of endogenous AVP, there will be a rise in plasma osmolarity and sodium. It will increase the plasma AVP normally. Due to the increase in plasma AVP, there will be increase in urine concentration, but that is often subnormal. And polyuria per se, it temporarily reduces the capacity of kidney to concentrate urine. This was all about the pathophysiology of diabetes insipidus. Keep watching the subsequent sections. Thank you.